Good afternoon, everyone. My name is Amy Cross, and it's a pleasure to welcome you to Moleculera Labs webinar on the Cunningham Panel and patient selection. The Cunningham Panel can aid in your diagnosis and treatment of patients with basal ganglia encephalitis. If at any time during the webinar you have questions, please use the chat or the QA function on the right-hand side of the screen, and we'll answer them either on the spot or during the live Q&A portion at the end of the presentation. There will also be a recording of this webinar sent out to all who have registered and attended within the next 2 or 3 days. Leading today's discussion is Dr. Craig Shimasaki. Dr. Shimasaki is the co-founder and CEO of Moleculera Labs, a neuroimmunology precision medicine company focused on identifying the underlying roots of neurologic and psychiatric and behavioral disorders that are triggered by an autoimmune response. Dr. Shimasaki started his career at Genentech and has been in the biotechnology industry for over 35 years. As a scientist, his work spans all stages of research and development, from bench to bedside. His research includes epitope mapping for an HIV vaccine, genetic breast cancer risk detection biomarkers, a rapid influenza diagnostic, and therapeutics for infectious diseases, neuropsychiatric disorders, and noise-induced hearing loss. As a business person, he co-founded multiple companies and led multiple products through the FDA approval process and is a co-inventor on multiple patents. Dr. Shimasaki received his BS in biochemistry from the University of California at Davis, his PhD in molecular biology from the University of Tulsa, and his MBA from Northwestern University's Kellogg School of Business. He is an adjunct professor at the University of Oklahoma Price School of Business and teaches biotechnology entrepreneurship. Dr. Shimasaki's passion is to help translate scientific and medical discoveries into acutely needed products so that more patients can live healthier lives. So without further delay, Dr. Shimasaki, the floor is yours.
Thank you, Amy, and thank you all for attending today. So I'll talk to you about the biology, but I want to share a little bit of background to help you as you practice and see patients to be able to recognize some of these different types of symptoms, but how this biology occurs and really the categories of treatments that are involved. We won't get real heavy into the treatment details. That we'll save for another talk, but I would like to at least touch on the major categories of those therapeutic modalities that are most effective in addressing and ameliorating these patient symptoms. So with that, I want to share with you that we're going to cover 4 topics. First one is, how can infections trigger an autoimmune dysfunction that do result in these neuropsychiatric and behavioral symptoms? And then secondly, why is it that certain infections tend to be present in these patients with these immune-mediated neuropsychiatric disorders? You may have heard of the term PANDAS and PANS, or maybe post-treatment Lyme, of course, long COVID. These have very similar etiologies in the sense, the mechanism of these are infection-triggered autoimmune neuropsychiatric disorders. I also want to share with you how the biological targets or antibodies directed against these targets in what we'll call the Cunningham Panel can help diagnose and direct therapy in your patients. We'll talk a little bit about the common symptoms that you may see in these patients and the therapeutic categories that are effective in addressing the underlying root of these patients' illnesses. So with that, this graphic here says that as you know, currently in the DSM-5, many of these different disorders, and probably the majority of all of them, are categorized by clusters of symptoms. So, for instance, a patient that might present with motor or vocal tics for more than 12 months would meet the definition of Tourette's syndrome. Again, other types of combination of symptoms make up ADD and ADHD, certain types of anxiety disorders, etc. But the thing that's important to recognize is that these psychiatric disorders are diagnosed entirely on clinical presentation. They're really not looking at the biology, but these disorders have a wide range of symptoms and causes, and of course, then they vary with treatment responses. So the standard care or medical care for these neuropsychiatric and various behavioral disorders typically focuses on treating symptoms. And so there's the advent of psychotropic drugs have really helped in medicine quite effectively. But if the underlying root is not necessarily traditionally psychiatric, but maybe autoimmune, these tend not to be effective. Other treatments are psychotherapy, institutionalization, and unfortunately, what we do see is that there is an increase in suicide rates with the use of antidepressants. And if you talk to many of these patients, and one of the neurologists who treats many of them says that if you ask any of them, and these are patients that have these autoimmune encephalitis, that suicidal ideation is a common indication that they struggle with. So we go to the real question: can infections trigger neuropsychiatric disorders? So this is something that is addressed in this publication in JAMA Psychiatry. In 2019, they published a study from Denmark of over 1 million individuals who were followed from birth to age 18. What they found was that if one of these individuals were hospitalized for a severe infection, what they found was that they had an 80% more likelihood or increase for being diagnosed with schizophrenia, autism, OCD, ADD, ADHD, any type of personality or behavioral disorders, oppositional defiant disorders, and tic disorders. So the authors or the editors in this journal accompany the author's paper said, how could exposure to infections affect the brain mechanistically to give rise to mental disorders? They said circulating autoantibodies that enter the brain via a compromised blood-brain barrier bind to neurotransmitter receptors is a potential explanation. And this mechanism has been proposed in PANDAS and other mental disorders. So the interesting thing is that infection-triggered autoimmune neuropsychiatric disorders are not new. In fact, rheumatic fever, which we know is triggered by a streptococcal infection, has been described in the 1800s. And Sir William Osler described these bizarre and precipitative behaviors in children that were called chorea minor, that accompanied patients that was a neurologic manifestation of rheumatic fever and named this Sydenham chorea. So we know that group A strep, which results and can result in acute rheumatic fever, is also the underlying infection that triggers Sydenham chorea. And Sydenham chorea used to be known as St. Vitus's dance, in which the symptom manifestation were these abnormal movements, loss of motor control, and then even loss of emotional control. We'll talk a little bit more about the target in the brain and how these things affect and actually impact the types of symptoms you'll see. The other thing that's important to note is that neuronal antibodies or autoantibodies are continuously being identified and discovered. And you can see many of them listed here, GAD65, you can see NMDAR receptor, glutamic acid receptor. Many of these autoantibodies directed against these targets can interrupt the normal neuronal functioning. So really, how does this occur biologically? So if you look at this, we all get microbial, viral, fungal infections at some time. And then we all make antibodies that recognize these infections to ward off and fight off these infections. And that's a normal function of our adaptive immune system. These antibodies, though, that certain individuals make are made because they are cross-reacting with neurologic receptors to a portion of the infection, which we'll talk about, and this process is called molecular mimicry. Once that occurs, that these antibodies are formed and they cross the blood-brain barrier, they interrupt normal brain function, and they can trigger these symptoms and various heterogeneous symptoms. We call these like a friendly fire in the wartime, where difficulty in telling the good troops from the enemy troops. And so when these antibodies cross the blood-brain barrier and interfere with normal neurologic function, you end up with various types of symptoms. And some of these can include anxiety, aggression, rage, OCD, tics, depression, hyperactivity, and many more. And again, treating symptomatically and diagnosing by symptoms, these patients will tend to be treated with psychotropic drugs. In the case for these patients, these drugs typically do not work and they're not responding to them at standard treatment or dosages. And in many cases, they actually become worse. Interestingly, during the COVID pandemic, we did see patients develop what's called long COVID or PASC. These patients end up with very similar types of symptoms in the sense where they can have autoantibodies directed against parts of the brain, resulting in brain fog and other types of neuropsychiatric disorders, but also to the heart, cardiovascular, to other parts of the body. And this is because of the molecular mimicry that is contained within the spike protein, which we'll talk about here in just a minute. So I mentioned the NMDR or NMDAR receptor, the methyl D-aspartate receptor encephalitis, which is also another condition that results in seizures, paranoia, psychosis. And if you have not heard or read the book called Brain on Fire, Hollywood made a movie, so you can watch the movie called Brain on Fire. But this was Susanna Callahan, who was a New York Post journalist, suddenly developed this psychosis and all sorts of neuropsychiatric symptoms that required hospitalization. A physician then did properly diagnose her that this was an infection-triggered autoimmune condition and treated it appropriately, and she's well and able to tell her story. What we're talking about here is more common antibodies that seem to be present in patients with milder symptoms. And in this study here, what you can see is that children that had developed OCD and tics that were associated with the streptococcal infection had elevated, let me get my laser here, elevated and increased inflammation in the caudate, the putamen, and the globus pallidus in the brain, which is all part of the basal ganglia, but not the thalamus. And we do know that the basal ganglia is responsible for voluntary motor control, different types of learning, and then cognitive functions and our emotional functions and eye movement. So you can see the connection between inflammation or antibodies directed against these targets in the brain and the resulting symptoms that are seen and often seen in patients with these autoimmune encephalitis, or sometimes this can be called basal ganglia encephalitis post-infection. So this brings us back to nomenclature, and it's important because we want to name and identify clusters of patients that we can study and have characteristic ways in which they could be identified and treated. PANDAS is one of those. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder associated with a streptococcal infection. But we do know now that other microbes can also stimulate and trigger these autoantibodies that result in similar symptoms. These include Lyme, Mycoplasma, Babesia, Bartonella, and certain types of viruses. And then even there's a belief that certain other types of environmental triggers and biologic factors can trigger these autoantibodies. So you have both infectious triggers and non-infectious triggers. And this is where the term PANS came. PANS, as you can see, which is different from PANDAS, does not end with the S, which is a streptococcal infection, but it's agnostic to the infection or the trigger, but it still refers to pediatric and acute onset. So those are two criteria that have to be met in order for that diagnosis to be made. Others have posed other types of nomenclature. In one case, ANDL, autoimmune neuropsychiatric disorder associated with Lyme, and sometimes it's referred to as adult neuropsychiatric disorder associated with Lyme. And again, we're really talking about similar etiologies, meaning infection-triggered autoimmune neuropsychiatric disorder. The terminology can be confusing because if you're not a pediatric patient, you can't have PANDAS, but you can have the same symptoms and the same types of etiology. So there is some proposal for basal ganglia encephalitis to be a term that's used, or autoimmune encephalopathy secondary to infection, or immune-mediated basal ganglia encephalitis. Whatever you call it, it is important to recognize what the underlying root is in order to be able to treat it effectively. So you're looking for something that would be triggering autoimmune antibodies directed against parts of the brain that result in inflammation and result in symptoms that are identifiable as neurologic, psychiatric, or behavioral. So other immune-mediated disorders are common and known. Rheumatoid arthritis, as we know, is where the immune system is attacking the joints, the synovial fluid, and cartilage. Diabetes type 1, we know, is where the immune system is attacking the pancreas or certain cells that produce insulin. Multiple sclerosis, we know it's where the immune system is attacking the myelin sheath around the nerve and triggering these different types of neurologic issues that result from multiple sclerosis. PANDAS and PANS, portions of things that we call autism, maybe ADD, ADHD, schizophrenia, bipolar, can be where the immune system is attacking parts of the brain, in particular, parts of the basal ganglia. And so this phenomenon of immune-mediated disorders is not new. It's just new in the sense that we're recognizing that this can be one of the reasons for various types of treatment-resistant neuropsychiatric disorders. So why are certain infections tend to be present in these patients with these immune-mediated neuropsychiatric disorders? So PANDAS, of course, the S is strep. Why is strep the one that does produce this? And why do other individuals who get strep don't get this? Because strep generally will occur in about 98, 99% of the population at some point. Why don't we get 98, 99% of the people that get PANDAS or PANS? It's a great question. Same way with neurologic Lyme and long COVID. Well, one of the things that we do know is there are certain infections that are more frequently associated with these autoimmune encephalopathies. And again, group A streptococci, or the strep, which is underlying PANDAS, influenza, varicella, mycoplasma, Lyme, Babesia, Bartonella, Coxsackie virus. And one of the reasons is because, we'll go through here, there's some sequence homology between parts of where the infection has a sequence of peptides that are identical to parts of the brain in which, if an antibody is directed against it, will then be directed against the cross-reactive part of that brain. So to go back really to immunology, as we mentioned, our adaptive immune system will be producing these long-term antibodies to fight off the infection, but also for any future encounters with infections that are similar to it. We call these targets epitopes, and an epitope is just part of a molecule in which the antibody recognizes as being foreign, quote unquote, foreign. And when it does that, it actually triggers the rest of the immune system, the T cells, the B cells, and then we develop what we call memory B cells, which is why we get vaccinated, is because we want to develop memory B cells that will remember that particular epitope or that particular organism in the future, should we ever become exposed to it again. And then it'll turn out antibodies pretty quickly. Well, what happens if an antibody that is made to an epitope of, let's say, streptococci, that actually is identical, let's say, to an epitope of a part of our motor neurons? Well, once that's made, that antibody will identify and seek to actually target and destroy anything that it recognizes that's a similar epitope. And this is how we get autoimmunity, cross-reactivity. There's some other mechanisms, but molecular mimicry is one of those that seems to be very prevalent. So we call this an autoimmune response through molecular mimicry. And really, basically, as I mentioned, it's friendly fire. You think of that in the wartime. There are genetic factors that typically are identified in patients that have these different types of autoimmune conditions, and they are those genes that are involved in the major histocompatibility complex, the HLA class 1 and class 2 genes. And these are the genes that tell us to recognize what's self and what's non-self. We won't go into that too much, but normally we make antibodies, at least the beginning of antibodies that could recognize really any antigen that would ever encounter. And then our immune system through our thymus and through the lymph nodes will screen out those that are self. And in these cases, when there's a genetic mutation or something in these genes, what we find also is family history of autoimmune dysfunction is typically seen in these patients with these immune-mediated neuropsychiatric disorders. So if we look at strep, there is molecular mimicry between group A strep and certain antigens that are self. So this is a strep bacteria, and on the surface, there's group A carbohydrates and M proteins. These M proteins, there's about 100 different serotypes, and they're typically used to protect the bacteria and camouflage. And what happens is that these M proteins, certain M proteins, have common sequence homology to the heart or the heart valve or parts of the proteins in the heart valve, which is why we get rheumatic fever in some patients. Then, of course, Sydenham chorea, where the patients actually then have these antibodies directed against the basal ganglia or the part of the M protein that's very similar to the basal ganglia. You can see in certain patients, you'll see arthralgia. You also see kidney glomerulonephritis. And so various types of disorders you'll see here are a result, in this case, from this common sequence homology where antibodies are directed against a target that is common to a part of our body. Molecular mimicry is also seen in narcolepsy. It's now known that particularly influenza A, the H1N1 type, what you can see is that, and this has occurred with some of the vaccines, is that a patient will then make, again, antibodies against certain parts of the presenting epitope that's common to, in this case, it's common to other parts and what's called hypocretin and orexin. And then this is part of the sleep-wake cycle. And when you have antibodies directed against that and the immune system targeting it, you see the narcolepsy. So there's also molecular mimicry between Borrelia, which Lyme, burgdorferi, Lyme, and streptococcus. So this outer surface protein A on the spirochete for Borrelia has sequence homology to one of the same proteins on streptococci, which is the M protein. Again, remembering that's one of them in which the targets generate and identified that end up with rheumatic fever and Sydenham chorea. So in this publication, they said that antibodies against Borrelia burgdorferi cross-reacted with strep pyogenes or streptococcus M and myosin, and both share sequence homology with the outer surface protein A of Borrelia burgdorferi, suggesting a role for molecular mimicry in the generation of these antibodies. So this also helps us understand why infections with Lyme can generate similar types of symptoms with neuropsychiatric disorder, arthralgia, various other things that are similar to patients that we might see with PANDAS and PANS. This even goes further, and we see SARS-CoV-2 spike protein. If you look at the D1 and the D2 loop, these are dopamine D1 and dopamine D2. These are receptors in the brain that we're going to talk about a little bit more, that there is sequence homology between the spike protein of SARS-CoV-2 and the dopamine D1 loop and the D2 loop. And so the green indicates where there's sequence homology between them. And so if an antibody happened to be made against those particular targets, you can imagine then you're going to get cross-reactivity then between the patients, in this case with the dopamine D1 and the D2 loop in the brain. So if you kind of put this in practical matters, these two twins said, one said, "You don't get lunch. Mom thought I was you and fed me twice." So it's just a mistaken identity, but it's triggered by a sequence homology in the context of a genetic predisposition to self, non-self dysregulation. And that's really how, one of the ways in which we get autoimmunity. So I want to move over to how the biological targets in the Cunningham panel can help diagnose and direct therapy to your patients with these immune-mediated neuropsychiatric disorders. So over 20 years of research on Sydenham chorea led to the identification of 4 biomarker targets and a cell stimulatory assay. And this is a report. If you run a panel or a test or had us run that and ordered it for your patients, the report would look like this. What we find after 15,000 patients that have been tested and reports from various doctors and identifying, there's a strong correlation between when a patient has an anti-dopamine D1 antibody, and we see various types of presentations of neuropsychiatric symptoms, including mood swings, depression, anxiety, irritability, aggression, delusions, and sometimes even psychosis. When we find autoantibodies that are directed against dopamine D2, we see patients have some type of movement disorder, might be small, maybe it's choreiform movements. They might have a diagnosis of ADHD, possibly Parkinson's. So we see that with various type of movement disorders. If a patient has antibodies directed against lysoganglioside GM1, we typically see that they may complain of joint tissue, connective tissue pain. And then antitubulin, we refer to this as the OCD cluster because typically what we see is that patients will present with OCD, or sometimes they often complain of brain fog, intrusive thoughts, sometimes food phobia, and even various types of issues related to these. Now, the 5th assay, which we call CAM kinase 2 activity, this is associated with the activation of the sympathetic nervous system. So we see that these antibodies actually can trigger symptoms that you might see with fight or flight behavior. These can be separation anxiety, urinary problems, bedwetting, sensory sensitivities, even dilated pupils, mydriasis. We have seen that when this is elevated, it does suggest that there is still an active infection of some kind, because remembering, in order for these antibodies to be stimulated, you have to have an infection that triggers it. So often we see that over time, as these infections are resolved, and usually there's typically more than one infection, these patients, the antibodies or the CAM kinase will go back down to baseline. If the neuropsychiatric symptoms and other symptoms continue, we'll see the other types of antibodies become elevated. So really what we want to see is all of these going back to baseline with the successful treatment. I'll share with you a few case studies, and these are pre-treatment test results of a 21-year-old young man who had one antibody target positive, and this was the CAM kinase. He had gradual onset of OCD and tics. He'd lost 30 pounds and couldn't concentrate. Separation anxiety, again, a lot of the fight or flight sympathetic nervous system stimulus. He had an anti-DNase positive titer, meaning strep. Also had been positive for rheumatic fever, again, indicating of family history of some form of immune dysfunction. And the treatment was IVIG and plasmapheresis, which resulted in the complete symptom reduction. And as you can see, his post-treatment test, which we perform on many patients, you see the resolution to that and the recovery from the patient. A couple more case studies, again, a 24-year-old young man, very similar situation, resulted with IVIG and plasmapheresis and symptoms reduced. This 9-year-old girl had OCD behaviors, verbal tics, and an autism-type stimming behavior, difficulty concentrating, sensory abnormalities, motor lability or emotional ability, behavioral regression. She had 2 positives and 1 borderline. And this patient actually was identified early on, and I believe she had a strep infection that was not really detected. They did treat her with azithromycin and rapid improvement of all of her symptoms. This is the importance of early detection, because if you can catch it early enough before the immune system develops too strong of a memory immune system, typically by getting rid of the infection early on, you can ameliorate a lot of the symptoms prior to the B cells and the memory B cells being strongly activated. Another 9-year-old girl, in this case, she developed neuropsychiatric symptoms, but was Lyme disease positive. And she had all sorts of complaints, but one of them was, "Mom, something's happened to my brain." She had 3 positive autoantibodies, which is why we test for all of them. Her treatment was a whole host of antibiotics and 3 IVIG treatments. Again, the immune system and the anti-infectives with complete symptom regression. We have a case report here that's been published and peer-reviewed that this one is related to that we can send to you. Another case, the 9-year-old male, 30 days post a strep infection, developed OCD and tics, couldn't concentrate, urinary frequency, dysgraphia, inability to draw, aggressiveness, choreiform movement. Again, 1 autoimmune target positive, and this patient had 1 IVIG, and within a month, a complete symptom elimination. All post-treatment, all his antibodies went back to normal. So these are just some examples of how the targets in the panel can help you identify and direct treatment towards your patients. We see some amazing recoveries. This is a snapshot of a video that Grace's mom took when she was 8 years old and was diagnosed with a mental disorder. She was trying to kill herself, and the parents emptied her 401k twice. We were able to test her. Her treatment was changed, and not too long ago, her mom sent us a picture of her all well, now on the cheer team, back to normal life. And so we like to hear these stories. We encourage people to send them to us so that we can remind us how important it is to be able to diagnose these patients early. So what are the common symptoms that patients present with that are associated with these antibodies being positive in testing? Well, they do follow various symptoms that are characteristic of the diagnosis of PANDAS and PANS, but there are many that don't necessarily are also just PANDAS and PANS. We find that they are treatment resistant to standard neuropsychiatric drugs at standard dosages. They tend to be treatment resistant, or in many cases, they actually get worse. We see that they typically can be exhibiting frequencies of infections, but they also may be subclinical. So it's not always just that they've had many infections, but typically they will harbor multiple infections. Sometimes they're diagnosed with Lyme or post-treatment Lyme, and they may have a family history, a majority of the time, of autoimmune disorders. We see sometimes that there's sudden or rapid onset of these symptoms. They were normal for a period of time, and then these symptoms came on. The PANDAS and PANS is defined by an acute onset, but in some cases too, they're gradual onset. And that's also patients that we find that are positive for these autoantibodies. OCD is another one. It's a hallmark pretty much for PANDAS and PANS, these obsessive compulsive disorders. Restrictive eating disorders. And again, this is not more an identity or an image disorder. It's typically an OCD where patients may have fear of food contamination or fear of choking. So it really is a type of an OCD. Motor or vocal tics, or small types of choreiform movements, anxiety, rage, emotional ability, depression, developmental or behavioral regression. Mydriasis, again, dilated pupils, again, going back to the CAM kinase positive, urinary frequency, bedwetting, and then a relapsing remitting course with sometimes dramatic exacerbations in OCD. And as I mentioned, one of the neurologists that treats many of these individuals can say, if you ask them directly, he said literally all of them have admit to some form of suicidal ideation. So it's important to diagnose early, and of course, PANDAS and PANS is another diagnosis. PANDAS and PANS is a clinical diagnosis. The testing that we do is an aid to your diagnosis of patients with infection-triggered autoimmune neuropsychiatric disorders. So I'm going to kind of wrap up here with one study that was published here, at least that we have on 58 cases. We looked at those that had 2 or more panels done between 2013 and 2016. And we also looked for those that monitored the symptoms and identified whether or not they improved before and after treatment and had a post-treatment test. And so we looked at examining, was there an association with these autoimmune antibodies being elevated and patients having these neuropsychiatric disorders, and patients that actually resolved these symptoms, whose symptoms were resolved, and the absence of these antibodies. And so we examined that in this study. And what we did find in both groups, those that actually got well and those that didn't, was they all had multiple infections. And on top of having strep infections, many of them had Lyme, Mycoplasma, Coxsackie virus, Epstein-Barr virus, Babesia, Bartonella. You can see many of these different infections. And it tends to be the case because they become somewhat compromised and they will have multiple infections. We also see group 1 is the group that improved. So group 2 is those that didn't improve after treatment. But prior to testing, they all had very similar symptoms. So decreased concentration, OCD, emotional ability, sensory symptoms. So there was no difference between their symptoms in those that improved and those that did not. What we did find then in those that prior to treatment make this a little slow. All of these that actually improved after treatment had one or more autoimmune antibody present positive. And so in this group that actually improved after treatment, you can see a vast reduction in the number of positive tests or the severity of the positive tests. So they either improved or completely resolved. And this is the sensitivity of 88%, specificity of 83%, overall accuracy of 86%. And we're working on an algorithm here to improve weighting of these different tests, which is not yet published out there. We can get the accuracy up to 90% by weighting different tests. Conversely, to those patients who did not improve, let me see here. We got that. Well, I don't have that one in this particular slide, but if you'd like the publication, I'll send that to you. So those that did not improve actually got worse, and they had more positive tests than they did prior to it. So there's multiple published research out there for patients that are been diagnosed with autism and had autoimmune encephalopathy that were positive in the panel and responded to intravenous immunoglobulin, those with Lyme or post-treatment Lyme. Other types of studies that showed with the patients that actually were diagnosed with schizophrenia who were positive but then responded to plasmapheresis and IVIG. So really the goal of why we test and the goal of why you should consider testing is you want to identify patients that have these neuropsychiatric and behavioral disorders into those that are infection-triggered autoimmune and those that are not, because the treatments are different. Standard psychotropic treatment medications will be effective for those patients who are not autoimmune, but is not effective for those who are autoimmune based. What we're going to in the next level is we're looking at various treatments, and we're using artificial intelligence from over 15,000 patients that we have now tested to see if we can actually identify prior to treatment what patients will respond to which medication based upon all the data of patients now that we have collected. So that's the goal of what we're working towards, to be able to take a test, identify whether or not that's autoimmune or not, which is what we can currently do today, and then be able to predict which treatment would be the most effective of these immunomodulatory, anti-infective, anti-inflammatory treatments, rather than a trial and error. But currently today, we can separate these into two camps, those that are autoimmune, those that are not. You may be familiar with the testing process. We certainly are here to help if you're interested. It's 2 red top tubes, and again, they need to be the red top tubes because there's no additives that interfere. The charge is $9.95 and $4.95 deposit. We actually courtesy bill insurance on behalf of the patient, and then FedEx will bring this to us overnight. We will run all 5 tests. This is a high complexity laboratory. It generally will take us anywhere from 2 to 3 weeks turnaround because of the complexity, and then you'll receive notification and a report via the secure portal. At that point, as I mentioned, we courtesy bill the patient's medical insurance and generally will get some type of insurance support unless it goes to deductible for the patient. And we also are available for online report access and consultation. And then we're here to support you and your patient's needs. So in wrapping up here, what I want to talk about is some therapeutic categories that have shown clinical effectiveness for these immune-mediated neuropsychiatric disorders. And generally, they fall into these 3 buckets. One is you first have to identify and treat all the infections. So as I mentioned, there's a list of sort of what we'll call bad actors that typically show up that have common sequence homology. But then there are other infections that typically tag along. So in order to be able to dampen or at least correct the immune system, you want to get rid of any kind of infection that is triggering the immune system. So those you generally will know anti-antibiotics, antifungals, antivirals, etc. Often there'll be a need to provide symptomatic relief. And again, the recommendations many times is very low dose SSRIs, because normal dosages patients just actually may get worse. So sometimes there's a need to do that, but again, it's not standard dosage. The other thing you want to do is to treat the inflammation, remembering the brain in this case. Many of these patients have inflamed brains, and treat the inflammation pathway. And the third treatment modality is treat the immune system. And these are the three categories that are most effective for patients with these typical infection-triggered autoimmune neuropsychiatric disorders. So clinical evidence has demonstrated that when there's biological evidence of an autoimmune neuroinflammatory disorder, that these patients respond to anti-infectives, anti-inflammatories, and immune modulators, and temporary symptomatic treatments. Again, these fall into the antimicrobials, anti-inflammatories such as steroids, and even a trial of NSAIDs sometimes. Plasmapheresis, immune modulatory treatments like intravenous immunoglobulin. For patients that typically are really challenging, we have some neurologists that typically will treat with rituximab. And rituximab, as you may be familiar, will remove the B cells. And again, the reason for that is you have memory B cells that are producing antibodies, and you're removing them, then the patients can repopulate without these B cells that have an autoimmune target. Again, temporary symptomatic relief, cognitive behavioral therapy, low-dose SSRIs. So there are reports you can see, and these we can provide to you if you're interested. You can see in this study just the treatment here, in this case with Septinar, looking at change or the reduction in the motor abnormalities and the vocal abnormalities, and then overall global tic severity scores. So you're looking at 30-day studies showing a treatment for antibiotic Septinar used for treatment-resistant OCD. There was one study here that was published in the Lancet, looking at intravenous immunoglobulin versus placebo versus plasma exchange, and the Yale-Brown Global Y-box score here. I believe that's what that is. So you look at the reduction using IVIG, no change in the placebo, and then plasma exchange, very significant drop. Again, plasma exchange is removing the antibodies that are in the patient's serum. And so you'll see generally a very rapid response in that case. And then if you'd like to download the treatment guidance for PANDAS or PANS, it's in the Journal of Child and Adolescent Psychopharmacology, or we can send you these. There's a 3-part articles on management of the psychiatric and behavioral symptoms, the immunomodulatory treatments, and then the other prevention and treatment of the infections. So these are best practices that are available, and they can be guidelines for not just PANDAS and PANS, but other immune-mediated neuropsychiatric disorders. So in winding up here, really we think we're at the tip of the iceberg, because there are many other chronic disorders that have portions of them that are triggered and can be triggered by an immune-mediated reaction. And the brain is the last frontier in medicine, and it's important that we identify, because so much of what we might call mental illness may be a biological condition that's treatable. So the challenge for you and the patients with these autoimmune neuropsychiatric disorders are kind of like in this cartoon, we're taught never ever think outside the box. Well, it's important that we do that. And we're here to provide free consultative services to you. So for the clinicians, our direct line there, and then actually Amy, who was our moderator here, will be happy to speak to you on this, and that's her number. The office can answer any kind of questions logistically or ordering or things like that. We also provide free in-service education or symptom association, target consultation, or even in-service to your staff. We have other resources, videos, publications on the website. So thank you for attending and listening. And we're going to wrap this up and open it up to some questions for the time remaining. We appreciate your work at the front line taking care of these patients.